Our guest presenter today is Raissa Souza, a PhD candidate at the University of Calgary, and one of our 2023 Research Award recipients. Raissa's presentation today will be on collaborative AI for improving diagnosis of Parkinson's disease. The research aims to develop collaborative AI systems to enhance Parkinson's disease diagnosis while keeping patient information private. Raissa graduated from Sao Paulo State University in Brazil in 2017 with a bachelor's in computer science. She also studied abroad at the University of California, San Diego, and became passionate about applying computer science to improve healthcare as a trainee at the University of California, Los Angeles in 2015. She is currently pursuing a PhD degree in biomedical engineering with a medical imaging specialization at the University of Calgary. Her primary focus is on developing distributed learning methods capable of leveraging insights from data across hospitals worldwide, thus creating new opportunities for applying machine learning models to improve health globally. So I'll turn it over to her to share with us her research.
Thank you so much for the introduction. Let's just share my screen. Can you see my screen?
Yes.
Great. So thank you so much. And yeah, as Bri already introduced me, I work here at the University of Calgary under the supervision of Dr. Forkett. And as the title of my research already suggests, I'm kind of looking through collaboration across the world so we can improve the diagnosis of Parkinson's disease. But before getting into my research details, I'd like to talk a little bit about artificial intelligence systems in general, just to get everyone to follow the ideas and how we can apply it for Parkinson's. So most of us use some systems in our work or just to chat or just to entertainment. And we don't really realize that those systems are using artificial intelligence. So one example that we have here, most of the time now when we are sending an email to someone or when we are texting someone, we get some suggestions of words to complete our sentence. And these suggestions of words, they also have AI systems behind it. So it's pretty much a system that know what is the next word that it's more logical in that sentence, and then it just suggests to you in case you want to use it. Another common example that we have is with the streaming platforms. Here I have an example of Netflix. So most of the time when we are just like logging into our accounts to choose something to watch, we have these recommendations. Oh, you may like this movie, you may like this TV show. All this recommendation system, it's also powered with AI. So pretty much what those systems does, they kind of learn the things that we liked or the things that we saved in our list to watch later, or it also looks to the things that we already watched and then suggest us some things that are similar, because if they are similar, there is a high chance that we will enjoy watching them as well. Similar to these streaming platform, we also have now a lot of ads, which I do agree also that it's quite annoying when we receive all these ads when we are just searching online or just using our social media app. But it's kind of the same concept behind it. So there is a AI system that just kind of learn based on what the things that we watch in the social media or the things that we liked, the things that we search, and then it suggests us a product or a service that we were looking for before, or just something that we like in general. And I think that the two most popular applications of AI at the moment is the Tesla and the ChatGPT. So Tesla, to be able to self-drive, it also has AI behind the scenes. So the AI system learns what is a car, what is a traffic light, what is a pedestrian, to be able to take some actions, because we don't want accidents. So to know when to stop, when to reduce speed, all those things, all those actions, they are all based on these what we call object recognition, the things that are in the scene for the car. And ChatGPT, which became very popular lately, it's what we call large language model. So pretty much what ChatGPT wants to do is just to mimic us, to mimic how we summarize a text, to mimic how we would answer a question, and it's trying to replicate how human language look like. And this became so popular that even if you don't really interact with ChatGPT per se, their application, many other applications are using this ChatGPT with new features. One example of that is this app called Blocks. It's kind of like a meeting system. So when in the past we had someone just listening to all the discussions in the meeting and then taking notes to have the minute in the end. So this app is doing that. It's just keep track of who is speaking, what they are discussing, and then in the end, it used these language models to summarize what that meeting was about and what are the actions that needs to be taken from this point now. All these examples here, it is just to show and illustrate that we can have AI system with different types of data. So we had examples that use text. We had examples that use scene, learning objects. And then I showed the last example about audio. It will learn through the voices and the audio of the meeting. But then one thing that all these systems has in common as well, independent of the type of the data that they are trying to use to teach this system, it's how they work, their logic, kind of like their brain. So just to understand a little bit how this it's working and really suggesting us a movie or suggesting us the next word and all those things. Let's think about a very simple example here. It's just apples and orange. So let's say that we have a bunch of figures of apples and orange, and then we want to teach a AI system what is an apple and what is an orange. When we teach this system, so pretty much what this system will try to do, it will try to learn what are the patterns that make an apple and an orange. And then with these patterns, what will happen is that this artificial brain will create this artificial boundary that groups the orange together and groups the apples together. And then if we think about, okay, but what really this system using? In this example, we can say that the features are color and shapes. Apples are red, orange are orange, and their shapes differ. So those are two features that this system can be using to create this artificial boundary and to group these two fruits. And this is pretty much what happened with all these systems. So they kind of learn how to group words, how to group objects, and how to recognize all those things to then give us some recommendation. But now if we think about healthcare and how we can then bring this idea of these AI systems to healthcare. In the healthcare ecosystem, we have a lot of different types of data. We can have the electronic health records, we can have the blood work results, we can have imaging such as the magnetic resonance imaging, the microscopy imaging, and nowadays we also have the smartwatch data, the fitness track or any other device that you can use to track your health. And then with all these data, how we can then use what we have available in the healthcare system with the AI ideas and then improve Parkinson's disease diagnosis. One of the applications that is the one that I will be talking here today, it's about diagnosing. And it's kind of the most common that we have nowadays in healthcare. So it's pretty much teaching this system to identify and group who is sick and who is healthy. But there are other applications that we can have in healthcare, such as lesion localization. Given an image of a tissue or an organ, these systems can learn and delineate where we have a lesion in that tissue. But we can also predict risk of death, we can understand the disease progression, and then we can correlate different types of data together, such as genetic traits with the imaging features and all those things. So the problem that motivates us to use AI for Parkinson's disease is as I will be describing here now. So if we just think about our Canadian healthcare system, when we are not feeling well, we will go to our family doctor clinic or to the closest hospital or just to a walk-in clinic. And then if we are a patient that with Parkinson's disease, when we are at those clinics, some of the things that can be the doctor will like ask us some um, to talk about our symptoms, what is going on, kind of like interview to get how we are feeling. The doctors then can ask us to have some exams, but most of the symptoms of Parkinson's overlaps with other movement disorder diseases and also with normal aging, which kind of make a little bit harder for the doctors at the first moment to already get that person is with Parkinson's disease. And when this disease is in the early stages, those symptoms may be so subtle that the doctors may attribute their causes to other diseases that are not even related to movement disorder. And because the family doctor and the neurologists from those unspecialized clinics, they were not trained for those diseases, they will be less skilled as the doctors from the movement disorder clinics because they have more experience for movement disorder diseases. So with all these kind of limitations, what these will impact is that will delay to referral this patient to a movement disorder clinic, which most of the time we already have a waiting list. And then in the end, what happens is that we delay treatment. So thinking about how things work in our health system and how AI is helping us in all these other fields, we decide to then investigate how we can use AI and the data that we generate in the medical and then in the healthcare system to see if we can expedite this process. So if you are not familiar with, I think that not most of the people, but a lot of people already had a magnetic resonance imaging. So it's pretty much this scanner that it's showing here in the video. We just go through this machine, which I know that it's quite uncomfortable because you cannot move and it's quite loud. But the good thing about this type of machine is that it generates for us some images that we can then study and understand the structure of the brain and the function of the brain. And this process, it's non-invasive. So no one needs to go under a surgery or have like anything invasive for us to be able to look to their brains. So the goal of our work here is to then use these images that are not invasive to understand how the structure of the brain changes when we have Parkinson's disease and how to use AI to then make the process to get to a treatment faster. So similar to the apples and orange example, pretty much what we do, we teach this AI system with these brain scans. And then what this AI system will try to do is the same thing. It will try to find what are the patterns that make the sick group together, the health group together, and create this imaginary boundary that make them apart. So pretty much looking through this imaging and then finding what are the features there that are associated with the disease, can be related to the disease or to normal aging, normal brain. And then one thing, it's much harder than the apples and orange example here. It's that we cannot quite tell just by looking at this image what those features are, because they are like black and white, just brain delineation. It's pretty hard. So how can we trust these features? Do we have like any mechanism to make sure that this system is looking into the correct regions of the brain? Yes, we do. We have these other techniques that they are called explainable AI, explainable artificial intelligence. And pretty much what those techniques does, they will give us this more colorful image. And what this colorful imaging is showing us here is the regions of the brain that was used for that decision. So if this brain is from a individual that is sick, it's just highlighting which regions of the brain of that individual was used by the system to take that decision. So it's like the important features. And with this image, what we have is that the clinician then can assess and evaluate, can I trust then the system? Does those regions make sense for Parkinson's? And then take other actions after that. But that's the way that we can explain which features our system is using. But then how all these will work in practice? I know that it's a little bit abstract, AI per se. So let's imagine that we have this clinician that is looking through some scans, and then he thinks that this individual is sick, but he's not 100% sure. So this clinician needs a second opinion. And then what this clinician can then do is he can ask the AI system and say, hey, do you think that this is Parkinson's disease? And then what this system will answer, it's a probability. So this system will say, well, I think that there is 76% of chance of this individual be sick and 24% of being healthy. And here are the regions of the brain that I used as important features. And then once the clinician get the second opinion, the clinician can agree. If the clinician agree, and then what will happen, the clinician can then refer to a movement disorder clinic, which will end up expediting the treatment. But the clinician can also disagree. So if the clinician disagrees, this clinician may call another doctor, may investigate further, and this may delay the treatment. But the one thing that it's very important to highlight here is that the clinician is the one that will decide in the end. The AI system is just this second opinion. So the same way that Netflix recommend to us a movie, it's not mandatory that we watch that movie. We watch if we think that makes sense, that we will like, that we will enjoy. So in this context, it's the same thing. The clinician will judge in the end if that second opinion is valuable or not. But the final decision, it's always from the clinician. Of course, to create these systems, we have a lot of challenge, and now it's where my research comes to place. So the first challenge to create those systems is that we need to see a lot of data. Data here, we need to see a lot of cases. We need to see a lot of cases of patients and also a lot of cases of healthy individuals. So that system can learn how to better separate these two groups and create this imaginary boundary. So if we just think here that we have an specialized hospital and then the movement disorder clinic, and both of these hospitals, they are creating their own systems. So because one is specialized and the other one is not, most like the population that the movement disorder clinic assists, they will be older, just because how the disease manifests in most of the time, while the unspecialized clinic will kind of assist a younger population. Because of that, we will also have these differences where the unspecialized clinic will have more cases of healthy individuals, while the movement disorder clinic will have more cases of the patient with Parkinson's. And then because the movement disorder clinic receive a lot of referral, it might have more cases in terms of quantity. So all these differences, if these two hospitals develop their system, and then now a clinician is using this system as I just illustrated in the last slide, if suddenly this movement disorder clinic received a patient that is younger than the population that the data that it was used to teach the system represented, most likely when the clinician asks this system, hey, do you think that this individual has Parkinson's? This system will say, well, I think that this is a healthy brain, just because this system never saw someone that was younger. So it didn't learn how a younger brain looks like when they are sick. And this is what we call the challenge of data. We need to have like all this quantity and diversity. I know that it's quite hard to understand with this age example. So I just want to illustrate again with the apple and orange example. So going back to that first time that I introduced this example, if we think that we have this system, its system knows very well how an apple is and how an orange is. If suddenly we have a green orange, and then we ask the system, hey, do you think that it's an orange? Because the system never saw a green orange, it will say, well, I have 42%. I think that there is 42% of chance of being an orange and 58% of chance of being an apple. The system don't know because it never saw that example before. So that's pretty much what happens when each clinic wants to develop their own system, but this system do not see a lot of different cases. So quantity and diversity, it's very important for us to be able to have this system that will be reliable and can be used by clinicians in the future. So one way that we have to solve this problem is, let's say that these two clinics now, they partner with us here at the University of Calgary, and then they send us their data. And then we will be responsible for implementing, teaching this system. Now, because we have the data that has younger population, older population, more healthy cases, and more PD cases, our system will perform better. We'll have better chance of identifying those cases than when they do their own system. But the problem with this is that nowadays we have so many data regulations in place that they protect this action. They don't want us to transfer data because they don't want to have the risk of exposing some private information about the patient, which is grateful and it's wonderful, but make the research in terms of developing these AI systems is lower and more challenging because combining data was the way that we had to get all this diversity that we need for the system to work better. And since this is not possible anymore, that's where my collaborative AI system comes to place. So what I want to do in my research is, instead of like asking these hospitals to share their data with us, we send our AI system to be trained at those hospitals. Because the best way of keeping data private and safe is to not move the data at all. So if the hospital is the one that owns the data and keep it safe, we reduce a lot these chances of these private information leakage. So this is what I've been investigating in my PhD. And in our scientific paper, we validated that this idea will work with 83 hospitals. And what we learned from this work is that it demonstrated that it's possible to then address this data sharing issue and all these regulations and achieve the same performance than the strategy that share data, which is good because now we have this mechanism where data keeps its privacy, but the reliability and the performance of the model is the same, so we can use it in practice. And then the other thing that this work demonstrated to us is that now we can enable any hospital to participate, independent of its location. Because I sent my AI system to them, if they are in Australia, if they are in Brazil, if they are in Europe, anywhere that they can participate and collaborate with us, which is good because then we will be able to learn how Parkinson's disease manifests in different populations. And there is no restriction of the quantity of data that they have. If it's a rural hospital and they just have one case, they can still collaborate and let our system learn about that case as well. Of course, this is all good news, but with this new approach, new obstacles arise. And then one of the obstacles that arise with this approach is that because the AI system is moving from one hospital to the other, and the hospital will still have their unique population, their different amount of cases, all those things, there is the chance that this AI system can learn some information that it's not related to the disease to perform this task, such as the sex or the age of the demographics that this hospital has, or even the number of healthy individuals and the number of patients with Parkinson's. It could also learn that, oh, because there is just two examples here, it's from the unspecialized hospital, while because there are several examples here, I don't know, like 100, it's from the movement disorder hospital. And it can also learn things about the scanner, the machine that was used to acquire this data. So all this made us wonder if our system is then using the information that is truly related to the disease, or if our system was now learning this other information that should not be learned because there is not relationship with the disease itself. So we investigated this in two ways. In this other scientific work, we look to the data itself. So our question was, instead of teaching this system to identify patients and healthy individuals, can we identify which hospital acquired this data, just giving the same MRI scan? And surprisingly, the answer is yes. Even though just by looking with our eyes through these scans, they are all black and white. Somehow these systems, because they use their like mathematical mechanism, they can find some differences that it's not visible to our eyes that make them able to identify the hospitals. And then in this other approach, instead of looking to the image itself, we were wondering more, okay, we have this system that we taught it how to identify healthy individuals and patients with Parkinson's disease. Can we use these features that this system is telling us that it's important for Parkinson's and say which hospital acquired that data and which scanner was used to acquire that data? And surprisingly, once again, the answer is yes, which showed to us that the disease information and the hospital information, they share similar features. But we don't want to use these features. We want to use the features that are more representative for the disease. And if they still share some features, we want to be able to minimize the features that are about the scanner, because the scanner don't really matter for us. What matter for us is the features for the disease. So just to summarize what we learned with these two work, we learned that the brain MRI scans encode information beyond disease traits, even though we cannot see them with our eyes. And we also learned that this AI system can often use this information, which is not great. And in these two works that I just talked about, we identified that a scanner was being the information that those systems were using wrongly. Because we have 83 sites, 83 hospitals collaborating with us at this moment, we have like more than 20 different scanners. And then somehow they change slightly these scans in a way that those systems can use this information. So just to illustrate again how this scanner can affect, going back to the apples example and the orange, because I think that it's easier for us to picture it. If we just have this new system now, and then we have these apples and orange, that they are still red and orange, but the saturation change a little bit. So we can see that the system can identify what is an orange and what is an apple, can create the imaginary boundary. But now we can see that there are more than one group of apples and more than one group of orange because of the saturation. So this system now, it's probably using color, shape, and saturation as a feature. So what happens if we ask if this very saturated fruit here is an apple? Is that this system may think that this is an orange, just because the saturation, it's more close to the saturation of the oranges. So this system is using saturation as a feature that it's more important than color and shape, which is not good, because color and shape informs much more what it's a fruit than the saturation. Saturation should not be relevant to this task at all. And this is pretty much what happened with the scanners. So they kind of create these subgroups, which make the model think that because the scanner of this vendor was used, this is a patient or a healthy individual, which is not good. So to minimize this problem, we went back to our collaborative system. And then now, instead of just teaching this system to learn how Parkinson's disease look like in a brain, we are teaching two tasks at the same time. The first task, we ask the system to learn patterns that are related to the disease. So how Parkinson's disease look like in this brain. And then in the second task, we also ask the systems to unlearn patterns that are related to the scanners. So we want to improve the ability of the system to identify patients and healthy individuals, while reducing the ability of the system to use the scanner as an information for that task. And then we perform these two tasks at the first hospital, and then we send our system to the next hospital, and then we repeat this. We perform again these two tasks. Once we did that, we were able to improve the detection of Parkinson's disease in our systems, and also to reduce the ability of using a scanner. This work is under review in a journal, but we really like and we are happy that we were able to achieve this second step and minimize this challenge. But one thing that happened with all the work that I had done up to this point is that I was always evaluating and assessing the ability of my system across every hospital. So considering the overall distribution, the overall amount of people that I have in my database, which is great that the system work. It's showing that we can in the future probably be using this type of systems in the healthcare. But one thing that it's not great is that because we are not moving this data around, these hospitals will always have different population, different representation of the disease and the health subjects. And then what happens is that these systems, they may perform slightly different at each hospital. And this is not good because we want to develop a system that independent of the location, the population, and the amount of cases that a hospital contributed to us, we want this system to have similar performance. We don't want to have like more misdiagnoses in one hospital than in the other one, just because their population differ. This is not fair to the hospitals, not fair to the patients. So what we are doing at this time, we are investigating how these differences in those hospitals can interfere or affect the amount of misdiagnoses at each individual hospital. So we look for age, sex, the amount of PD cases, the amount of data in general. The reason that we look for the amount of data in general, it's because in this AI field, most of the time, people will blame that the systems do not work as they were expecting because the hospital did not have a lot of cases. But what we learned at this point is that the amount of data per hospital has less impact than the number of patients and healthy individuals. So what this means is that does not matter if one hospital only has 2 cases, but one is a healthy case and the other one is a patient. And does not matter if a hospital has 100 cases, where 50 is one, it's like patients and 50 is healthy individuals. What matters, it's more when one hospital only has PD cases, because that hospital never showed us some healthy brains. Then it's in those hospitals that our system it's not performing as we would like to. In other words, it's where we are having more misdiagnoses. And then when we look to the population that it's being misdiagnosed, we try to look to their age and sex and their if they are healthy or patients to try to understand if there is any pattern there. And then we learned that healthy individuals that are older and males are more likely to be misdiagnosed as patients with Parkinson's. And that patients with Parkinson's disease that are younger and females are more likely to be misdiagnosed as healthy individuals. Of course, and I really want to stress this here, all this conclusion, it's specifically for the data that we have access to, so to the 83 hospitals that are collaborating with us at this moment, and to the AI system that we developed. If another university is developing another system and they have access to other hospitals' data, their performance and their conclusions will be different. So this is what we learned from our data. And what we want to do now in the future, based on everything that we learned up to this point, so now we want to account for these hospitals' differences, to then have our AI system that it's not only collaborative, but also fair, because we do believe that we should not have disparities and more misdiagnoses just because a hospital has more PD cases or more younger males or more older females. All these things should not matter. What matters is that our system is able to learn the true patterns of Parkinson's disease. So just to summarize my research then, what I have done so far, I developed a collaborative AI system that avoids data sharing. So we don't need to receive data from any hospital, and we minimizes the usage of scanner as a feature because we don't want this system to use this information that it's not relevant to the disease. What we want to do next, we want to account for differences between hospitals to reduce misdiagnosis rate, to just make this system fair to everyone. And then our target is always to help clinicians and to expedite patient treatment. So what we envision for this system is that patients can then get referral quicker and then start their treatment quicker in the future. I'd like to thank the Parkinson Association of Alberta and the Hopkins Brain Institute for the support for my research, but I also would like to thank a lot everyone who has consented to the use of their data for research purpose. Because everything that we learned until now and everything that we believe that we can still implement to make this process faster, it's because we have volunteers and people that allowed us to use their data for research. And I also would like to thank my lab for their support through my PhD journey. Thank you for your attention, and I would be happy to answer any questions.
Wonderful. Thank you so much. That was fantastic. I've got a couple questions here already that were messaged to me throughout, and I think I see some popping up in the chat as well. The first one I have is asking if these systems that you've kind of been working with can be used for like Parkinson's plus diagnosis. So like Lewy body dementia, multiple systems atrophy, and can they tell these neurological disorders apart, or does it just flag these brains as kind of unhealthy?
That's a great question. So just to break down, to answer that, yes, we can have a system that learns multiple disorders. Of course, as I mentioned, like a lot of these disorders, they have like overlapping symptoms. So could be harder to teach this system when we ask the system to learn all these disorders at once. But to one approach of doing this, it's pretty much the final part of the question. So it's kind of what we called anomaly detection, but it's not like something very abnormal. It's just what you can do when you want to be able to flag all these brains that don't look like normal. You can teach a system just how a healthy brain look like. So this system will never see any disease. But then you then give this system a brain that is from someone that has some of those diseases. And then if this system understood well and learned well how a health brain look like, it will be able to tell you, yeah, this is not healthy. It will not tell you which disease, but will be able to filter to you and then say, I think that this case needs more attention. I think this case needs more attention. So those two approaches can be taken with those systems. And yeah, of course, each of them has their difficulties. Teaching a lot of diseases at once, it's hard and you need more and more data because then you need like more and more representation for all diseases. But then you can also just have this first filter so the clinician can go there and see like, okay, so let's try to identify then what this patient has.
Excellent. Thank you. Got another one here asking how accurate is this like current technology to kind of traditional diagnosis, like of a doctor reviewing each of these like scans or cases individually?
Yeah, that's a great question again. So I think that Parkinson's disease, the usage of like medical imaging for Parkinson's disease diagnosis, it's quite new. So we don't have a lot of work out there. My system, it's performing like it's getting 75% correct in terms of like saying that it's health and patient. And this is pretty much the same level that the other systems of other researchers in the field, which comparing with the clinicians, I don't have that answer. To be very honest, I'm not quite sure if they also miss like 25% of the cases. But what I know is that the same cases that are hard for our system is the cases that are hard for the clinicians. That it's when someone it's already like older, because normal aging also shrink the brain. Normal age also enlarge the ventricles, which are kind of like the first patterns that they try to look for. And also because when we are younger and when the disease, it's like very early stages, it's quite hard to visually see those changes in the brain because they are very subtle. So I think that in terms of the cases that are hard for clinicians and those systems, I think that they are the same. And the number for how well a clinician does, unfortunately, I don't have that number.
That's fair. Thank you. I've got another one here asking, what are your AI predictions for AI in kind of Parkinson's care in kind of the next 2 to 5 years? Where do you see this going? Any new developments that you're aware of?
Yeah, that's a great question. I think that the biggest step, I mean, that I think that we will see in 2 to 5 years, it's we need to get some regulations. So I think that we will see more changes in the law side of things, because I think that at this point, what it's hinder us the most is AI evolved so quick, and then the law didn't really follow. So we are kind of backtracking, trying to judge what it's a good application, who is responsible if these systems fail, how to like manage all this law side of things. So in terms of real world application, I think that we will see more changes in the law. In terms of research application, I do think that we will still see more coming up. At this point, I am just investigating, for example, how we can use this information that it's in different hospitals to teach those models. But we will see other research in terms of how do we make the communication with the hospitals also safe. So like also something in this privacy lens. So I think that we will see more things in the privacy field to then get the approvals from FDA to start really using it in practice.
Wonderful. Thank you. I've got another one here, looking at kind of so that specialized MRI time, not very readily available, often not very available in some of our more rural areas, but the SPECT or PET scans, is this something that might be a part of this AI diagnosis or that can be utilized more in it?
Sure. I think that the other kind of approach that many people are taking right now, it's what we call like fusion systems, where you don't use just one modality, but you can leverage information because we have like all these different type of data, right? So we could also leverage information from the health records, and then we can have like this language model to go through and try to find if there is any keywords there that can inform us that it's a patient or a healthy individual. We can have systems that combine multiple modalities. So we could have like a system that combine the MRI and also PET scan, or MRI and CT, that it's computer tomography. So yeah, I think that it's true. MRI it's quite expensive. So the waiting time, also like all those things. But I also believe that if once we pass this law, kind of barrier to use these systems in practice right now, I believe that if we get FDA approval to use these systems in the practice, let's say the system that I am developing at this point, just using MRI data. I believe that if we have that, I think that they will prioritize to get those MRI because the time that we will save for the patient to start treatment will be much important. Because if they don't prioritize to get that type of data, all the other exams that they can try to use to find what this patient has will also cost a lot to the government. So I think that once we start using that in practice, we can also see some changes in terms of this data modality being more accessible, because in the long term, it saves more money for the government and helps the patient faster.
Excellent. I've got one last one here. It's asking if you see potential or if maybe this is something that kind of your program is already doing, but utilizing this AI kind of system in rural settings to help get more or better specialized care where there isn't the specialist. Like if they're, can take these images that are done, get them to a specialist to review them, even if they're not in their location or city or patient load yet.
Yeah, that's a very good question as well. I think that at this moment, what we envision is that will be the places where these systems will help the most. Or with like low income countries where we don't have skilled radiologists, where we don't have skilled neurologists. Because at the movement disorder clinics, they are great and they perform better than us with AI system because they were trained to see those differences in the brain. So they can get those subtle differences like much easier than those other systems. But when we think about the rural places or when we think about countries that they cannot afford to hire a lot of skilled neurologists, that's where we think that AI will be able to impact the most in terms of bringing benefits and also to get these second opinions kind of scenario. And one thing that we are doing here in my lab at this point, thinking about that, one thing that is important for my system, I do have more than 20 hospitals that are just providing two data, like two cases for me. Because we think that it's very important that we can learn from the data for the hospitals that don't have a lot of cases. Because some population will not have a lot of cases, or some locations will not have a lot of cases. So that's one thing that we are considering for my work. And there is another person here in the lab, but he works more with ophthalmology, but he's also looking for this point of care. And he's using my system to show that we can use cell phones to learn from the data. So if you just have like your own personal data, or if we have this case where we are in a rural area, we can then, they don't need a big computer, they don't need like a fence and a very expensive resource. They could use a cell phone and we can send our system to that cell phone and still learn from that data point. So those are the things that we are doing here in the lab, thinking about these low resource settings or more remote settings.
Wonderful. Well, thank you. That's all the questions that I've got here, but I got a few comments in here thanking you for also helping people understand AI a little bit better. It's something we do hear about a lot, but rarely do we get a good explanation on it. So I think that is also really helpful to help us better understand the work you're doing and the work kind of going on in different fields as well. So thank you, Raissa Souza, for taking the time to join us today for this webinar and presenting, and everyone who was able to attend live and share your questions.